Good morning, everyone. I hope you can hear me well. Thank you very much for the invitation to be here and to share some thoughts about women's cancers. Obviously, I'll have a little bit of a focus on breast cancer, but much of what I'm going to say applies to any of the women's cancers. So I'll start just with a few numbers that I'm sure all of you know very well in terms of the burden of cancer in mortality. What you see in different shades of blue is countries where cancer is the first cause of death or the second cause of death. But you can see that even in low middle income countries, cancer is already third and fourth causes of death. What is more shocking is that 7% cancer deaths occur in these low middle income countries. Now, these countries also have to deal still with the burden of communicable diseases, and so they have a dual burden to deal with, which makes things even more difficult. And for women, this is extremely important because in many of these countries, obviously, there's also the society weight on the women and the lack of resources and accessibility to care. Now, when we look in terms of incidence, clearly breast cancer is the highest incidence cancer. In fact, since 2022, breast cancer is overall the cancer with the highest incidence in both genders. When you can also see that in some of the lowest income countries, cervical cancer is still the one with the highest incidence. When we see the mortality, that changes a little bit because lung cancer has a very high mortality. And so in some countries, it still kills more women than breast cancer. But this is rapidly changing because of the increase in the incidence. Now, points about data that we have using breast cancer as an example. So we have relatively good incidence on relatively good data on incidence. So per year, we have 2.2 new breast cancer cases, and we have about 600,000 new cervical cancer cases. We also have good data on mortality. So per year, more than 600,000 women die from breast cancer and 350 from cervical cancer. And we have something called prevalence, which means someone who had a diagnosis in the last 5 years and is still alive. And this includes all the survivors and all the metastatic or advanced breast cancer or cervical cancer cases. And we do not know how many metastatic cancers exist in the world because our cancer registries don't register relapse. So this is a huge problem and one of the points we need to change. Points about research. The two main problems in oncology today have to do with selection of patient and tumor resistant, all these to provide the best treatment to the individual patient at the right time of the evolution of the disease. And how we have been trying to address these problems is to precision medicine, try to identify specific targets in the cancer cell, and then develop targeted therapy against those targets. Now, the problem of resistance is something that it's not always easy to explain. I heard the last session about communication, and this is one of the most difficult things to pass the message. So this is an example in a metastatic cancer, whichever cancer. You start from the left of your slide. You have a cancer that, as you can see, is not homogeneous, has different types of cells. We provide the best treatment according to our knowledge. Usually there is a response. the tumor becomes smaller, but after a while, the tumor adapts and is able to grow even in the presence of treatment. And then it regrows and becomes even more complex with even more mutations and harder to treat. What we need to do at that time is change the treatment, give another treatment, and hopefully there will be a response. So what are the consequences of this problem? Is that we need to find ways of assessing the biology of the disease throughout the disease pathway. And I'm sure Jelle can speak about this later on. And we also need to have access to different types that we call different lines of treatments. And this is important for the policymakers and the decision makers, because sometimes one treatment is not approved because there are other treatments. But we need many treatments to be able to provide different treatments throughout the journey. Now, one point about not forgetting metastatic or advanced cancer. I'll show you breast cancer as an example, and you can see that in the majority of high-income countries and in the majority of European countries, with one exception that we can discuss which one it is, since the 90s, we see this huge drop in mortality. And when you see something on a population level, is because something happened 10, 15 years before. So what happened in the late 70s, early 80s in breast cancer? We introduced screening and early diagnosis and the very powerful movement of education and and patient advocacy. But we also develop the best strategy. So the very simple treatments, but the first treatments, first chemotherapy regimen, first hormonal therapy regimen, they were introduced in these years, and then you can see this huge drop in mortality. However, when you look at the metastatic or advanced cancer, you see that the curves are superimposed for more than 10 years in this case, from 2008 to 2013 and beyond. So the advances in the metastatic setting have been very, very slow, and we can discuss the reasons why. Recently, we have advances to move this medium survival of 2 to 3 years to 5 years in two of the subtypes. What is the catch here is that this is through the use of treatments that are very expensive and not always available even inside Europe. Now, these patients feel very much alone and abandoned, and this was very much the case in the beginning of the 2000s. It has somewhat improved through efforts in the field, but they still feel isolated and not given the proper attention. Sometimes the breast cancer patients that have metastatic disease, they say that they feel lost within the pink movement because they do not have a happy ending. And I hope that we can come back to this point later on. One way of addressing this issue is what we have done with the Global Alliance, basically bringing everyone together to share resources and knowledge and to help the ones that need to advance faster, not to start over, but to use what's already been developed, adapted, of course, to their reality. One of the things we have done, the first thing we have done was together with all the stakeholders, obviously patients, patient advocates, healthcare professionals, and all other different stakeholders, develop concrete goals. And this is what we call our global charter. And you can see there that all these goals adapt to any advanced or metastatic cancer that you want. We want to improve survival, quality of data, quality of care, accessibility, communication, like you just discussed. And we want also to fight stigma around cancer and around advanced cancer. We want to help women or men with this disease to be able to continue to work and be a full member of and productive member of society. Now, a treatment can only be efficacious if it is accessible. And this is an example of the disparities in Europe. This is an old graphic, but I have other data that shows that this still is the reality in Europe. And what you can see is that countries cluster, and this red cluster that has the worst survival are all countries from Eastern Europe. And by the way, the country that doesn't have the drop in mortality is Poland. Maybe we can come back and discuss why this is the case. I would call the attention that today, all over the world, but particularly in Europe, inequalities are not just between countries, but within each country. We have to treat patients differently according to their health coverage. And for us, healthcare professionals, this is also extremely painful, but obviously the burden of all of this is on the patient and the family. One note to remind you that disparities are not just in very expensive treatments, but also in diagnosis with pathology and other technology that we need for the diagnosis. Access to radiotherapy is also very different, for example, from rural areas to urban areas. And access of inexpensive medicine. This is a huge problem in Europe. Currently in Portugal, we do not have tamoxifen, a very inexpensive drug, but we don't have it because it's not produced sufficiently. And access to pain control is also not uniform around the world, even around Europe. So there is excess of consumption of morphine in some countries and lack of morphine in so many others, leading to deaths in pain, and morphine is not expensive at all. We also need to change reimbursement rules in Europe because they are not patient-centered and they do not facilitate what patients need to have less toxic treatments or shorter treatments of radiotherapy. And we can come back to this. And the last point is why we are discussing about women's cancer is because women and the role of women in society still needs a lot of improvement, let's say. I don't have the time to go through all these numbers, but I advise you to read this gender snapshot from WHO. And I would just like to call your attention to this number here. It says that we do not do something different regarding women's rights, it will take us almost 3 centuries, 286 years, to achieve gender balance. I think that we can do better and faster. So finally, how can we address inequalities, develop and implement good quality guidelines, make sure women are not forgotten in major cancer initiatives, share and develop resources for underserved population, and use that also to share among low middle income countries, raise awareness and fight stigma, which is one of the things that we can all do together, and always involve the patient perspective, because in any other situation, if you are developing something, the end user must be involved, and the end user here for healthcare is obviously the patient. So I have great hope that these initiatives, the Europe Speeding Cancer Plan, as well as the WHO global initiatives that, as you can see, are very much focused on women. There is one for cervical cancer, one for breast cancer, and one for childhood cancer, and children always come together with their mothers. So hopefully these initiatives will improve the outcome for women's cancer. Thank you very much for listening.
Thanks so much, Fatima. You packed so much into that very rich presentation, beautifully presented. I think there's given us a lot to discuss in this panel. So thank you so much, and please stay if you would for the panel discussion. So could I invite Ulrika, Toby, and Jelle to join me on stage? Thank you. Thanks so much. Thank you. Yeah. Yeah, middle seat. Thank you.
Good morning.
Good morning, I'm Ulrika.
Hello.
Morning.
Do you mind if I sit here?
Sorry.
Oh, Yellow, do you mind if I sit?
you want to
Thank you, thanks. That's okay. Thank you.
Changing roles.
Play musical chairs. Good. So there was a lot to discuss there, and probably more than we can fit into this panel. But let's try to get as much as we can out of this. Ulrika, let me start with you. Sweden, I think, if anyone were to talk about Sweden, I'd immediately think, oh, well, they're an egalitarian society. The gender equality is, if anywhere in the world is going to be gender equal, it'd be Sweden. I'd be interested in your view on that, and also what you see as the priorities for women's health, bearing in mind you're representing Cancerfonden, which is the Swedish Cancer Society.
Yes, I think we all think about Sweden as a very equal country, but it's really not the case. And I think this presentation was very interesting by Fatima, and showing that there are differences even within high-income countries. And we know, for example, that looking at participation, for example, in the screening programs, we have lower participation among women, depending on their income and education and ethnical background, of course. So it varies a lot. And lung cancer is, of course, affecting women, especially with lower education, because they have been the ones who are more heavily smokers than women with longer education. We also see, in terms of participation in the screening program for cervical cancer, participation isn't equal, but we can see on the whole range that in terms of healthcare workers, looking at women and cancer from a holistic approach, of course, the majority of healthcare workers and healthcare and caretakers are women, but looking at the decision levels, it's not really equal. And looking, for example, at number of researchers and professors, we're not equal at all. We still have a lot more work to be done, and looking at the specific needs, putting women in the center of cancer from all different kinds of aspects. So still a lot more needs to be done, especially in terms of women with different income, educational levels, different backgrounds, and we're trying to address that in Sweden now.
Right. And would you say, I mean, which there's so much there, and one has to prioritize. Where would you see the most gain, do you think, in terms of improving the outlook for women with cancer?
Well, now we're targeting really on cervical cancer elimination, because we've sort of taken the decision that we want to be the first country in the world eliminating cervical cancer. So we really have a decisive program doing that, starting with vaccination, HPV vaccination for both boys and girls, schools grade 5. We tried to do it in different grades, but then when people moved around, we missed sort of some of the students, and it's of course for free. We had the screening program, trying to find ways to reach all women, to get them to participate. Not easy, but breaking it down to sort of small parts of municipalities, see where women don't participate, and trying to find ways to reach them. And it's a lot about health literacy. I think it was very interesting listening to our British colleague before, talking about how we actually use the language when we invite people to screening programs and to participate and to inform them. And we also now are doing a catch-up vaccination program targeting women born 94 to 99 with free vaccination for HPV vaccination, trying to reach them, which is quite hard because these are women in their prime. They don't really have cancer on their radar. They are well educated, but they have live busy lives, and the healthcare system isn't really sort of equipped to reach or to target this group. And we are trying to help them from the Swedish Cancer Society. But this has really been a decisive working together, research with sort of a good evaluated base of knowledge, working with sort of from a policy perspective, influencing our politicians, and being really decisive that we can do this in 5 years. We have sort of the health statistics and everything in place, and now it's just continue to do it.
I mean,
That was just one example.
yes.
Yeah.
I mean, maybe we'll come back because you mentioned about reaching into local municipalities.
Yes.
But we'll come back to that. So
Yeah, and how we work with immigrant groups, how we actually do that.
Yes, yeah. Jelle, I think your main interest is around screening and screening for breast cancer. And screening is often regarded as I think to the lay public as a panacea for things, but it does get more complex, doesn't it? So maybe you can talk a little bit about that.
Yeah, for sure.
Yeah.
We know, we go more for targeted treatment, personalized treatment, and these days population-based screening is a kind of one-size-fits-all.
Yeah.
So I think it's really relevant to move away from this. And one initiative that I'm leading right now is this Cancer Grand Challenge, as initiated, fortunately, by Cancer Research UK and NCI, the National Cancer Institute as well. There's KWF, Dutch Cancer Society, where you can put together all the best experts worldwide to address a major challenge, answering the questions when cancer is not really cancer, because we all know that we detect by screening a lot of lesions that might progress into breast cancer, but most likely never will, or the minority progress to invasive breast cancer. So all these women, almost all of these women are referred to the hospital. They are re-evaluated by the radiologist. A lot of them get a biopsy and they worry. So it's a major claim on your resources from a societal aspect, but also from a healthcare aspect. And as a doctor, I really would like to step down from this. I'm not at all against screening, but the only way to solve this is to do this together with the disciplines. Ultimately, I would not say patients, but all women confronted with a diagnosis of DCIS play a pivotal role in this initiative as well. So what we would like to do or are doing is understanding the biology of these lesions, predicting way better than we can do now, because we cannot predict it at this moment, which one is potentially hazardous and which one of these precursors is potentially or most likely harmless, and then step away from treatment, go just for your regular screening, and communicate this very well with the women involved that are not patients. They're just coming to the screening, which is a very different label, so to speak. Comes with a very different connotation. And I think this is it's a grand challenge in cancer research to personalize screening way better than we do now. So I think that's my intrinsic drive to do justice in a way to all these women that are worried so much about being referred to the hospital.
Right. And is this, I mean, from your way you're speaking, I'm not quite sure whether this is a future aspiration or whether this is already being built.
Implemented.
Yeah, well, I also initiated a trial about 8 years ago, the LORD trial, low risk DCIS trial, in which we randomized women with what we now call low risk DCIS between active surveillance versus conventional treatment. So that's surgery plus radiotherapy or even a mastectomy. That trial didn't run so well, and that was due to the fact that most women, and knowing my wife, I could have known that, they know what they want. They really would like to make the choice by themselves. So we transformed this trial to a patient preference trial, and since then in the Netherlands, this trial goes like, so we now include about 60% of all women in the Netherlands with a low risk DCIS lesion. And from these women, about 80% opt for active surveillance. So that is, I would say, a team play between the healthcare professional as well as the women involved. And I think this is absolutely in line with the Hippocratic oath, first, do no harm.
And is there, and this is a question to any of you actually, is there any evidence that this sort of approach, because one of the things we've heard is that uptake is really lacking. Is often and then so the uptake for this approach is much better, is it?
Yeah.
Okay.
Yeah.
All right.
Well, in the Netherlands, coming back to your point, 80% Although women, close to 80%, do participate in population-based screening, but still in the underprivileged parts, and there are quite a few in the Netherlands, and these parts are increasing in size, unfortunately. The disparities, they increase due to, I would say, well, no discussions here, but it's so the uptake is getting lower,
right,
unfortunately.
Okay. I'll allow Fatima, please come in on this, and then I want to hear from Toby in a second. So yeah.
Just a question for Yali. Don't you think that one issue that we could tackle is the name we give to ductal carcinoma in situ? Because if you call something carcinoma, a woman will be afraid that it's cancer, and most women with this doesn't know that it's just a pre-malignant lesion. So maybe for communication, like we discussed, we should change the name.
Right. It goes to the point about jargon and words and the words we use. Toby, I mean, please feel free to respond to any of what we discussed, but maybe you could speak to some of the advances we can look forward to in breast cancer and women's cancers.
Yeah, no, absolutely. First of all, comment to the screening in the UK. Screening uptake is around 60%, 60-70%, so still below what we achieve. And I think screening, we heard yesterday, a patient, once you have been diagnosed, once you had your surgery, and the monitoring of cancers, the patient was talking about, I need genetic testing, minimal residual disease. So again, on the other spectrum, patients have been diagnosed, have been treated with surgery, but again, knowing that particularly luminal A cancers can return up to 10, 15 years, how do we monitor these patients? How do we use the high-risk group who potentially relapse with modern technology advances like liquid biopsies, genetics? So it's one aspect. Yes, progress has been made, but not implemented or partially implemented. I think one point. The other thing, as a practicing clinician, what I'm still very surprised. We know very well the simple medical diagnosis history, about family history, who had cancer, not only breast cancer, but pancreatic cancer and others. BRCA gene, no one tests these, although it is implemented in guidelines widely enough to really save time for patients to then implement the right treatment, the right diagnostic path. So again, we have made lots of advances in diagnostics, genetics, but the implementation. Again, this comes up, I believe, it is an educational aspect. The primary, tertiary care service is not communicating on a level where you would expect. So it's a knowledge exchange we need to do. And again, I'm reflecting over the last 24 hours. It is a bit of, we in the ivory tower where we come up with all these new tests and testing, doing clinical trials, we probably could have done better, possibly. So, something to follow up. Technologies in terms of treatment, again, Fatima did a great job in really displaying the heterogeneity of breast cancer in particular, but it applies to ovarian cancer as well. It's not just a disease under the microscope, it's a genetic disease driven by different drivers. And of course, innovation is tackling, whether it's HER2, new antibody drug conjugates, new hormonal therapies, androgen receptor, and weird ellipsis, running clinical trials on this particularly a receptor which has been neglected for 30, 40 years and is relevant in breast cancer, for example. So great progress made, but again, it's the implementation. It's then, of course, the cost question. Innovation comes with costs, and we had great debates yesterday. So a few comments.
May I just pick up on that, because I think it's so interesting that you mentioned implementation, because I heard a figure from IARC that it actually takes 17 years from research to be implemented and reach patients, and only 40% of the relevant actually reaches patients, and it takes 17 years. So we're actually focusing now, how can we what can we actually do to shorten that, and we have proof of evidence, but how to make the last step in order to have it implemented, because that could really make a huge change if we could just change those figures a little.
That is striking, because I remember when I was training back in the 90s, and we had thrombolysis for myocardial infarction. That was 15 years from when the trials were done before it became a mainstream. I mean, so it hasn't improved.
No.
Yeah, interesting. There's a lot to pick up on. Fatima, there was a lot in your presentation. Feel free to sort of expand on any of the points you made, but what I was really interested in, which you can ignore if you want, but was the stigma aspect. And, often people, I mean, particularly in Europe, I'd be interested to know whether that, is the extent of that problem. And then the other thing that really struck me was access to very, very basic, not having tamoxifen in Portugal, or not having access to pain relief, and morphine or radiotherapy. Those really stood out for me, but feel free to address anything you wish.
Thank you. Yes, those 2 points are very important, very dear to me. So I think people believe that stigma is only existing in very low income countries. That's not true. I'll tell you a true story. You guys are in Brussels. I worked in Brussels for 10 years. One of my patients came back to me one day and said, I went back to work after having a diagnosis and being treated, and they put my desk in a separated room because they were afraid that it would be contagious. That is Brussels in the years 2000. So I think that comes as a reality shock to many of us and says that we cannot do sufficient awareness and information campaigns about cancer in general to the general population, because as Ulrika mentioned, some people don't have cancer in their radars, particularly young people who are not thinking that they can be affected by cancer. So I think information is still needed everywhere in the world, and stigma around cancer still exists. In the case of metastatic cancer, that's even more a problem, because there is a lack of knowledge of what is metastatic cancer. So what's the difference between the breast cancer that we see very often spoken about, the survivors, the high rate of cure, and the ones that have metastatic disease and that will die from that disease? People don't understand the difference, and the patient is lost in the middle of this lack of understanding. The issue, I don't know if you want me to comment already on accessibility or if you want to pause a little bit.
You mean, I mean, if you can speak to the accessibility of those sort of very basic elements of care, surgery, radiotherapy, basic drugs.
So the issue of inexpensive medicines is a very serious issue. And I don't think that policymakers and politicians and governments are really understanding the problem here. So most of our treatments, medicines, I'm speaking now about medicines, most of the treatments we need are not expensive at all. So about 80% of what we need to treat cancer is not expensive. It exists for many years. It's already on generics and biosimilars, but it's not profitable for pharma. Okay, so it's not produced sufficiently in the amounts that the world needs. So there's always shortage, and obviously, the ones that sell them, not the pharma that produces, but the distributors will give them to the countries that are able to pay more. So tamoxifen never lacks in Germany or even the Netherlands, but it lacks in lower income European countries, or countries that are not willing, the governments are not willing to pay sufficiently higher to have these drugs. If we don't do something about this, we are going to be unable to treat cancer, because the very expensive drugs are targeted drugs, are for a small percentage of patients. But those drugs that we are talking about, general chemotherapy, general endocrine therapy, they are very much needed for the majority of cancer patients. And I cannot understand why Europe doesn't create several factories of generics and biosimilars. It will be even good for the economy. And maybe that's not pharma that has to produce them anymore. They are not in patent, but we need to keep on producing these treatments or we won't be able to treat cancer one of these days. So for the lack of tamoxifen in a country like ours, I will give you a very concrete example of what that means. Tamoxifen is the treatment that we can provide to young women, premenopausal women. We don't have an alternative. The alternative is that we have to induce menopause to be able to give another treatment. So think about it. If you're 30 or 40 and you don't need to induce menopause, do you really want me to induce menopause to all these women because I'm lacking tamoxifen?
Mm-hmm.
And this is a problem in Europe and in high-income countries. So I don't understand why people just don't find a solution for this that would have been good even for economy.
Questions, slide. You can use Slido or put your hand up. Yella, you wanted to come back on something.
Yeah, related to the stigma, there's another stigma involved as well. A diagnosis, even for DCIS, comes with a stigma for getting a job, for buying a house. I mean, it's amazing what the consequences in your daily life can be. And that hurts the most for the ones that have a lower income, that are really so much dependent on having a job, on finding a house to live in. So it's again, when it comes to first do no harm, it's way broader than we think. Okay, in terms of surgery or radiotherapy, it's also so from a societal perspective. First, do no harm.
Toby, you mentioned you were reflecting on because it's relatively complex and because the treatments of the not just treatment, the whole management pathway is advancing and is dynamic. There's kind of, I know from my own personal experience, the active patient, the one who goes and reads or is or maybe medically qualified already, they know what to ask, they know what their rights are, what should be provided, and they're able to get it. They're able to speak to the GP, the oncologist, and they get what they want. It's presumably the same in many other countries.
We see that in our service.
Yeah, and for those who don't, or who are maybe more reticent to make noise, it sort of falls through the cracks, and you get to, so I mean, so it's not just to you, Toby, but where do you feel that responsibility lies? Is it patient health literacy, and you know, practically, how do we address that actually? Because the health system is under stress, cost containment stress. Doctors and nurses and allied professionals and everyone is worked to the bone. So they might want to say these things and might, but there just isn't the opportunity. The patients maybe are not as well equipped. So it's a really difficult. So I don't know, what are the different approaches we can use to address that?
Well, it's a big challenge. Of course, in our clinics we sometimes call them worried well, as in uber zealous in a way, getting information, often wrong information. Again, the real facts of breast cancer. What do I need to do? I have patients coming with 4, 5, 6 genetic testing. So effectively the absolute opposite what you want. You rather distribute 5, 6 tests to the people who didn't, or couldn't communicate, or the educated or uneducated physician didn't offer them the testing. So it is finding that balance and explain and effectively the reality, truth, fact checker on breast cancer. And again, platforms, charities could greatly support this to effectively help communicating and manage expectation. It is about effectively manage expectation and have a realistic discussion rather than I'm in the corner, I have to do something and prescribe and do another test, versus like these are the facts. And effectively it's about risk and reality about risk.
But I see a challenge here because I think demanding patients is one part of it with high education and demanding more time and more kinds of treatment or diagnosis. But what we see, and we actually looked into this a couple of years ago, and I was quite surprised to what the reactions were from the healthcare professionals when we sort of launched that report, because we were looking into the mortality rates depending on levels of education and socioeconomic differences, the whole chain in Sweden. And we said that part of it, of course, of prevention and how you live your life and differences in that. And part of it is in terms when you meet your healthcare professionals and the patient, because you don't get the same kind of diagnostic they aren't offered the same kind of diagnostic tools as is actually part of the standardized programs. If you are have a lower education or you can't really speak on your behalf. And the medical staff, when we presented this is the case actually. If you have a lower education, you're not sent to this kind of special diagnosis treatment, diagnosis, or use this tool to the same extent as someone with higher education. And they said, well, we treat everyone in the same way. So it was really sensitive starting to talk about this. Of course, now it's less sensitive because of course, the job is to treat everyone in an equal way, but that means really to treat everyone in a different way in order to reach equality. Yes. And we all know that, but we need to actually see it. What are the consequences in terms of survival rates, in terms of late stage diagnosis, in terms of what kind of treatment you offer? Because sometimes you might need them. We learned that during the pandemic that sometimes you need to have sort of a more expensive treatment because it means shorter time in hospital, because then the patient won't follow up the treatment afterwards if someone with sort of in a lower socioeconomic status. So it's really challenging and it's sensitive to talk about it.
Please, we'll get a microphone to you. Yes, but go ahead.
Okay. In the law trial, this is now a shared decision-making process, right? And we analyzed which women are participating. Well, in 60% of all women in the Netherlands, I would say these are not just the privileged, these are all. So somehow, and I think the nurse practitioners, etc., that's a level that is really able to communicate to every level of education or social, and that's very important. And that's, I think, why the trial in itself is such a big success, also among the, I would say, immigrants that are taking part in this, where we have, patient information file sheets for in the Arab language, in the English, the German, etc., etc. So I think there are lots of opportunities, but you really have to invest in this. But it is possible, and as I said, the law trial really highlights that very well, that through all layers, so to speak, there is a high participation rate because of this shared decision, personalized on your, I would say, social...
Being engaged and sort of owning one's own care.
Sky high,
yes, a question.
Yes, Peter Kapitein from Inspire to Live. I have a question for Jelle, and I have a question for you, Vivek.
Yes.
Jelle, you talked about the Cancer Grand Challenge.
Yeah.
And I think the mechanism beneath that determines whether cancer will be a real disease or not. The question is, why do we realize that is the case now and not 10, 20 years ago? But the more important question is, what can we do to speed up the process? Because we're dealing with the downside of screening. That's my question to you, and the question to you, Vivek. And that is, I was shocked by what Fatima told about the non-availability of tamoxifen and other medicines that are not very expensive. And that is a financial problem. That can be solved with financial engineering. So I would challenge you, that Economist, organizes a small conference or whatsoever with financial experts. I have a financial background. I work at the central bank, I work at the Ministry of Finance. I know how money works. And I think that can be solved with financial engineering so that you can make revenue and profit with cheap medicines.
Yeah, I mean, I would second that. I think we see in across healthcare there's market failures which are hugely detrimental to the health of our populations, and there's a lot to be gained in terms of product. I mean, if we're purely looking from an economic, never mind an ethical standpoint, addressing those market failures will pay back. So yeah, I'm with you on that one, and yes, I will take that back and try to encourage that in future conferences.
Yeah. So Peter, nice to meet you in person. The thing is, for example, you say for every woman that doesn't get surgery and radiotherapy, etc., you save in the Netherlands about 15,000 up to 20,000 euro. So we now already saved in money millions. This money, I would say, but we still have to find funding for this trial over and over again, because it's not, there is no connection between your saving the money versus the investment in the trial. So when it comes to quick implementation, there should become a connection between saving the money and that you have to invest to do the trial. That's the involved, what they call a kind of reimbursement mechanism. That's a financial issue that we struggle with. And Cardoso as well, he's also fighting for this as well, for the CDK4/6 inhibitors. And it's so the connection between health insurance companies versus what is saved in healthcare should be established.
Yeah.
And that's a technical issue, but we can have a chat later on.
Again, it comes to the economic models one uses to establish the worth and value. I just want to highlight a question that's come up, which I think could have been addressed. I mean, it's around misinformation and the fact that people will access media, and media is rife with all sorts, and it could have been addressed in the earlier panel. And I don't think we're going to have time to address it in this panel, but it's maybe I could pick it up with Matti in the next interview. Is the role of, but it's certainly something we need to discuss, and perhaps in the networking groups, and we've got a roundtable session, we can talk about that issue. I want to, because we've only got a couple of minutes left, so I just want to ask each of you a very sort of brief answer. One thing that can be done to improve women's cancers, and it doesn't have to be the most important thing, but that's asking you to commit maybe in short order too much, but something that you think is really important, some low-hanging fruit, something that we can really move the dial on, either on both equity and outcomes for women's cancer. And it could be within Europe, or Fatima, you may want to address it globally. But so who wants to go first? You've already talked about HPV, but
no, but I really want to follow up what Fatima started with, because it seems almost overwhelming, the challenges we have. But I picked up on one thing: is setting really bold goals and objectives. There's a lot of stakeholders can gather around, and we can do that in women's cancer. We can do that from different perspectives, having a holistic approach, saying this is where we want to be in 2030. And then you can join forces, researchers, academia, private sector parties, and patient advocates and patient organizations and cancer organizations in order to reach those objectives. But really putting bold objectives that we can work on together. And just one thing, I think one small thing that we can all do in our respective countries, because we are actually targeting a group of the new immigrants, focusing on awareness campaigns, information in easy Swedish language or whatever country you're from, reaching that target group, because there's a lot of sort of stigma from many of the immigrants coming from parts of the world where cancer isn't curable. So that's why they don't participate in screening programs, because why should I? Reaching those groups through sort of language courses for immigrants, for example.
Okay. Yeah, more from a, I would say, biomedical perspective, it's ultimately going for quality of life. We know that a lot of women, they receive systemic treatment for a very good reason, but we also know that many women will survive without a systemic treatment as well. And we really have to learn, I think it's worth to invest really in distinguishing, the groups that really need the systemic treatment for better survival versus the ones that do not need this. So there is a major gain and that will result in a better quality of life for many, in more resources, so to speak, less burden on the healthcare system.
Okay. This thing's flashing at us.
It's flashing,
yes.
but a quick one. Your question was so open. Of course, what we haven't mentioned here is clinical trials, access to clinical trials.
Yes.
1 in 20 women participate in clinical trials. That's not good enough. We have to increase this. So I stop there. Maybe next year at a clinical trial specific.
Clinical trials.
And it's about communication, access, and all aspects we discussed here, genetics included, and modern technologies. So
we had a session on clinical trials yesterday, but we didn't specifically address the issue of women's enrollment. But yeah, that's a good thought. Thank you, Fatima. Last word to you.
I would ask that those who take decisions listen to those who are living and working in the field, both from the patient perspective and the healthcare professionals. The 2 points we didn't discuss about the change in reimbursement rules in Europe. That is very easy to do and will save money, not spend more money. And the issue of inexpensive medicines, which can be solved and would be beneficial to everyone.
Great. Thank you very much. We've gone a little over, but thank you so much. We needed to hear that. Thank you. Thank you so much.